Hello, my name is Diana Clynes, and I'm the Executive Director of AAKP. I'm proud to have been with AAKP since 2005. In 2018, I was selected by our patient board of directors to serve as the Executive Director of the association, and I've been honored to implement and execute the mission and national strategy ever since. Across the globe, AAKP works closely with patients, medical professionals, researchers, and industry allies to address the many unmet needs of the kidney community. AAKP believes our expanding international footprint can help close the gaps in the U.S. and in countries where the healthcare systems and our infrastructure do not fully support patient consumer choice or immediate access to new treatments. It is my pleasure to introduce our session titled Patients Redefine Shared Decision-Making for Kidney Treatment, Moving Beyond the Limited Medical and Social Work Models. This is a follow-up session to our excellent shared decision-making session AAKP hosted at our Global Summit on Kidney Disease Innovations in July. Because it provides a strategic update to patients across the globe and here in the United States with practical and high-impact advocacy tools that are under development by AAKP. At AAKP, we are committed to providing patients with the tools and strategies to take control of their treatment as they define their needs with the nephrologist they choose and trust. Today, you will hear from two esteemed speakers, both dedicated to advancing AAKP's definition of what true patient-centered shared decision-making really is. Our forthcoming AAKP shared decision-making tool is unique. It reflects patient principles and priorities and will help patients better determine which treatment strategies work for them. AAKP is committed to patient-centered medicine. Over the past decade, we have defined shared decision-making quite differently than many other kidney stakeholders here in the U.S. and across the globe. In many countries, shared decision-making means the government wants to encroach on your care choice and access to life-saving treatments. Why? Because in many countries, government and other so-called experts substitute their views for the rights of patients. They think they know what's best for you. And in many countries, access to kidney care innovations is based on what governments or health economists define as quality-adjusted life years, meaning you can have access to care only if it extends your life based on someone else's definition of what your life is worth. AAKP firmly rejects any form of this thinking and ideology, and we are fighting it here in this country whenever it rears its head. We believe kidney patients are intelligent consumers of healthcare and have the same fundamental human aspirations as any other person. This means they share the same desires to pursue an education, work meaningfully in a full-time or part-time job or career of their choice, and also have the shared interest in having a family, owning a home, and retiring securely. This is part of the reason why AAKP defines kidney disease as both a healthcare and a workforce issue, as discussed in our Day 1 opening session. But in order to achieve their aspirations, patients must have care choice and timely access to life-saving treatments that fully align and support their interests. These include home dialysis and transplantation and preemptive transplantation. Deciding on which kidney replacement therapy aligns with the aspirations of a patient requires consultation with a qualified doctor who is fully capable and willing to think of patients as equal partner in the process and who has the thorough understanding and experience with how each therapy works. This is why AAKP is working closely here in the U.S. with the American Board of Internal Medicine to raise the knowledge and experience standards of certification for kidney doctors to include a greater understanding of home dialysis therapies. We think ABIM has made great progress to protect the patient's interest and to raise the standards for the nephrology profession. Doctors have an ethical obligation to fully inform patients of the clinical benefits and risks of one treatment option versus another, and they must understand that patients do not view these decisions simply through the narrow lens of medicine alone. Instead, these decisions impact the entire person's life, so naturally, patients talk to non-medical experts about treatment options to choose, including family members and loved ones, friends, and fellow patients, as well as an often overlooked concern of patients here in the US and around the world that most shared decision guides miss, and that is the importance of the role of faith, spiritual leaders, and beliefs and cultural values many patients have when they are deciding the best and most holistic treatment that works for them. This brings me to welcoming our first speaker, Mr. Chris Kelly. Chris is founder and CEO of Engage to Advocate. He is an experienced health literacy writer whose company has developed tools that provide health engagement among patients that promote critical thinking and lead to improved health outcomes through active learning, design, and behavioral changes. AAKP selected Chris to help us develop our new patient-centric shared decision-making tool. He joined us during our recent Global Summit to provide a sneak peek of this project and is back to share even more exciting work that has been done in preparation to launch this interactive tool. Chris, welcome back, and I turn things over to you.
Thanks so much, Diana. It's very exciting to be part of the 48th annual AAKP National Patient Meeting. It's an honor to work with all of you. So let's talk about our project objectives and why this is so exciting. Our first goal is to collaborate with kidney disease patients who are living with this condition day in and day out to develop the most impactful tool. The second objective is to support the most informed, effective, and holistic treatment discussions and decisions between patients, caregivers, and their healthcare providers. So why is this tool so exciting? It's really the first of its kind, and for 5 key reasons. Number one, it's aspirational, meaning it's not just about medical decisions and medical issues, but also psychosocial issues, things like hopes, dreams, life goals, work, aspirations. It's real world, meaning we sat down with patients and designed this tool with patients for patients. It's accessible, meaning it's grounded in best practice design, health literacy, and accessibility guidelines. It's unique in that we conducted a robust landscape analysis to identify those specific unique needs that need to be met by the shared decision-making tool, and it's global. We've looked at language translation and also tailoring it to reach all languages and countries. So let's talk a little bit more about what we mean by real world. We've conducted 4 intensive patient focus groups. We'll also be conducting a quantitative survey to ensure that this is a consumer voice and that all of our content, our tools, our imagery, our font, everything is informed by patients that are living with kidney disease every day. So let's talk about accessible. As I said, we conducted a robust landscape analysis. So landscape analysis means we're looking at the literature, we're looking at social media, we're looking at research that we received from AAKP. This includes 20 peer-reviewed journals, a review of international guidelines and standards, motivational interview guidelines, 5 to 10 kidney disease best practice shared decision-making tools that were already in the market, and also global shared decision-making tools. We left no stone unturned. So let's talk about global. When we say translated and tailored to reach across language and countries, what does that mean? So this means that a global shared decision-making tool must support and activate universal informed decision-making, or as the World Health Organization calls it, people power and intention to take action. We've looked at advocacy, community engagement, involving all patient types, age, ethnicity. We've looked at health literacy and informed decision-making, real-world experience, and power dynamics and power reorientation to ensure that this is a truly global tool. So what I'm going to do now is show you some examples of our work in progress. This first page shows you an element of a shared decision-making tool where patients have an opportunity to look at decisions from many different angles, or what we call domains in the health education field. Some of those core domains are looking at your valued roles. You're a parent, you're a worker, you may be part of a spiritual community, you may be a volunteer, and thinking about how a particular treatment decision might impact a role that means a lot to you. We look at quality of life. Things that inform quality of life are your independence, your ability to pursue hobbies and interests that you enjoy, the ability to manage pain, basically all those things that in many cases can keep people from doing the things that they enjoy. We look at emotions, things like anxiety, depression, but also very importantly on the positive side, joy and happiness. And, with COVID and pandemics and natural disasters, we're also looking at emergency preparedness, a person's ability to access treatment, even in the face of a disaster or pandemic. And the second page of our draft shared decision-making tool is directly asking patients to sit down and journal. Think about, when you hear the words dreams, hopes, and aspirations, what comes to mind? Is it something related to a field you're pursuing? Is it something that you're hoping for your family or for yourself? So in addition to looking at the medical side of shared decisions, this is a page that will ask patients to really sit down and journal and write down, what are your dreams? What are your hopes and aspirations? And how might a treatment decision impact those dreams, hopes, and aspirations? And then there's a prompt to share this tool with your physician, with your healthcare provider, so that you can have the most informed shared decision. Now let's talk about next steps. So we will complete our fourth and final focus group about a week from now and finalize the shared decision-making tool. We're looking forward to testing that prototype through a large quantitative patient survey with patient ambassadors. We'll finalize the shared decision-making tool. We'll do quality testing. We're going to do a small pilot to ensure that this tool is meeting the needs of patients. And then we're very excited to launch the tool so that patients with kidney disease and their healthcare providers can make the best decision for patients. So once again, I want to thank Diana, Paul, and the team at AAKP for the opportunity and the honor to support this project. Thank all of you for joining, and I hope this was informative, helpful, and exciting. Hope you have a great day.
Thank you, Chris. Excellent presentation. We at AAKP have been thrilled with the work accomplished and are very much looking forward to launching the tool later this year. I'd now like to welcome our second speaker and my friend, Jonathan Haydak. Jonathan is an AAKP ambassador based in New York. He was diagnosed with kidney disease at the age of 22 and started peritoneal dialysis at age 23 before receiving a kidney from his sister Rachel on March 14th, 2019, which also happened to be World Kidney Day. Throughout managing his condition, Jonathan graduated from the University of Florida with a degree in chemical engineering. He went on to receive his master's at Georgia Tech and is currently a PhD student at Icahn School of Medicine at Mount Sinai. Jonathan has a compelling story as he navigated life with kidney disease and the important role his family played in helping him through difficult times, as well as the decision to accept his sister's kidney. Jonathan, thank you for joining us to share your personal experience. I turn it over to you.
Hello, my name is Jonathan Haydak. I am a member of AAKP. I was on dialysis for 3 years, and I've had a kidney transplant for 4 years. I'm here today to talk about how patients can be empowered through shared decision-making. And to do that, I'm going to give an overview of my journey with kidney disease, starting with my initial diagnosis and then up until the point where I got my transplant, and talking about the role that shared decision-making between me, my medical professionals, and my family, and how that's played a role and how I've used it. So my journey with kidney disease started in September of 2015, when around this time my feet got really swollen. I went to the doctor, they did some blood work, and they found that my creatinine was very high and my EGFR was in the low 30s, and I was in pretty bad shape. So they sent me to the hospital, and from there I got some more blood work done, and they did a kidney biopsy, and they found that I had a rapidly progressive form of glomerulonephritis called ANCA-negative posse-immune glomerulonephritis. And so from here, my team and me had to decide what treatment plan to go forward with, because my disease was pretty aggressive, and I was going to have to start dialysis pretty soon if nothing changed. So they wanted to take an aggressive treatment plan with infusions of cyclophosphamide and high-dose prednisone, and the goal of this being to preserve my remaining kidney function for as long as possible to prevent me from needing dialysis in the immediate future. And although these medications were very strong and did have side effects, they reasoned that because I was young and didn't have any other comorbidities aside from the kidney issues, that I could probably get through a 6-month treatment plan without having any long-term side effects. Ultimately, I ended up starting dialysis about a year later, but I still think at the time that going through the decision-making process with my team allowed us to make the best decision that we had available to us at the time. And more generally, when it comes to kidney disease and the medications, I don't think that the picture is quite as cut and dry as it is as just going to your doctor's office, getting prescribed a medication and taking it, especially in kidney disease, because some of these are autoimmune in origin or they're very severe glomerular diseases, and some of the medications used are immunosuppressants, they're steroids, and they do have real side effects. And so as some concrete examples of cases where I think the time should be taken to have a shared decision-making process, some of these include the use of steroids and prednisone in IgA nephropathy, the use of prednisone for immunosuppression following kidney transplants, and then dietary management on dialysis. I know that for me personally, that last one, dietary management on dialysis, my tolerance of risk was much higher than what my team was comfortable with when it came to my blood work and the foods I could eat. So unfortunately, in November of 2016, I had to make another shared decision between me, my family, and the medical professionals as to what modality of dialysis to start. And this is a topic that deserves its own presentation and discussion. But briefly, we decided that, considering my lifestyle at the time, I was a PhD student and I was going into work every day. And I also liked to travel, so I was visiting friends from out of state quite a bit. That the modality of dialysis that was probably most compatible with my lifestyle as well as my personal and professional goals was peritoneal dialysis. And so with this, I was able to take my supplies, I could load up my car and do over dialysis elsewhere. And I could also take exchanges into work if I need to do it there. I was also I wasn't dependent on having caretakers, so I felt pretty independent. So this was also important in this decision here. So as many people with kidney disease know, the journey isn't without its hiccups. And so one of my major hiccups was in the early part of 2017 when my first PD catheter actually failed. And so this caused me to require a rapid transition into in-center hemodialysis with a chest catheter. And during this transitionary period, I ended up with quite a number of medical issues, including uremic neuropathy, I got gout, and a few other things. I also found that I didn't tolerate the in-center hemodialysis as well as I had PD dialysis. It interfered with my ability to go to work. I found that I was a lot more fatigued. I was more restricted into how much fluid I could take as well as what I could eat. Overall, it seemed like my quality of life was lower. And so then I had to make a decision by talking to my friends, family, as well as my medical team to see if I could try PD again. And so we ultimately decided that it was in my best interest and for me to try peritoneal dialysis again. And so I had another peritoneal dialysis catheter inserted, and make a long story short, I ended up restarting peritoneal dialysis. It worked much better than the in-center hemo. And so despite a period with a lot of procedures and medical issues, ultimately we came together to make a decision that was best for me, and it ended up working. So I stayed on peritoneal dialysis until my transplant a few years later. And so my journey to a kidney transplant after spending some time on dialysis really is the biggest example of the role of family in the shared decision-making process. My initial attitude towards getting a transplant or getting a living donor transplant when I started dialysis was that I didn't want to be a burden on my friends or family, and I didn't want them to have to deal with any complications resulting from donating a kidney. And so there were two factors that really helped me get over my reluctance to having a living donation. The first was after being on dialysis for several years, going through complications and really experiencing how much lower the quality of life is on dialysis. I was sick of it. I was much more open to anything that would get me a transplant because I just wanted to be off of dialysis. The second and probably most important factor was conversations with my family, my uncle in particular, who's shown in the middle here. My uncle is the patriarch of our family, and he has very strong opinions and is not afraid to voice them. And so in my case, he basically took me aside and had a conversation with me where he told me that it was not my place to deny my sister the right to do a good deed by donating her kidney to me. Now, at this point, my sister was open about the fact that she was willing to donate her kidney to me. The limiting factor in that was my unwillingness to accept it, to go through with it, because I was just scared for her. It was a lot. But after having that conversation with my uncle and then talking with the rest of the family about it, we really decided as a group that the best decision for me and the best decision for the family was for me to get a living kidney donation, and then for my sister to donate her kidney to me. And so shortly after that, we went through with the testing for her to become a donor. It went relatively smoothly. And then in March of 2019, I got a kidney from her at Columbia, and we're both doing pretty well. Not that life with a kidney transplant is without its ups and downs, but my quality of life is drastically better than it was while on dialysis. I'm very grateful that we came together as a family and made this decision. So in conclusion, I think that when it comes to medical decisions with care around kidney patients, especially in the later stages of kidney disease, that these should be a shared decision between the patient, the patient's family and caretakers, and the medical professionals involved. And all of these decisions should be centered around what is the goal of the treatment and how compatible is it with both the lifestyle and goals of the patient, both employment and personal goals. Thank you very much for listening to me. That's all I have to say. I'm very grateful for AAKP for giving me this opportunity to talk about this. Thank you.
Thank you, Jonathan, and thank you, Chris. I believe our speakers have done a superb job of outlining not only what shared decision-making is as defined by the patient, but also what shared decision-making is not. And that is a strategic distinction for AAKP. It is time as a community that we adopt the true definition of shared decision-making and recognize the important role of faith, family, and friends, as well as understand that no treatment is not really a treatment option. That is a separate decision made by a patient in consultation with those who are most important to them in the process, including doctors they trust. I'm confident that this tool being developed by AAKP will support that paradigm shift.